Welcome. This week we have a couple of different kinds of disorders to talk about. We're going to start off with a discussion on gender dysphoria. Then we're going to move into a category that looks at disruption, impulse control, and conduct disorders, mostly that we're going to see in younger children, but not all of them. So our first category is gender dysphoria. This used to be called gender identity disorder in previous DSMs. And this is actually something that's considered a really positive change, that we're not considering it an identity disorder anymore. We're looking more at just that sense of their assigned and experienced gender not being the same. One of the discussions about this disorder is that it should not be in the DSM at all, but then it was kept partially because, again, of insurance, that for people to be able to get treatment for gender dysphoria to actually transition to a different gender, they have to have something diagnosable and go through some mental health treatment. So we needed to have something in the DSM that would support that, and this was kind of the compromise of still having it in the DSM but not making it the disorder that it was before. So this is one diagnosis, but you'll notice there are separate criteria for children and for adolescents and adults. So depending on the age of the person you're working with, make sure you are looking at what those criteria looks like. And generally we're looking at that marked incongruence between the gender the person has been assigned and their experienced or expressed gender. That's the core of the diagnosis. For adults, you might notice that they also want to get rid of the primary or secondary sex characteristics and acquire the ones of the other sex. So women might want to have breast reduction surgery. Men might wish to have their penis removed. Lots of different surgeries that might go into this. We might also be looking at something that's not surgically changing things, but they're doing it by hormones. So that would kind of be the first step in the medical process. So you might also have people that are just adopting clothing and behavior of the opposite gender, their experienced gender. And this is kind of looked at the continuum. So if we're looking at doing something medically to change the physical experience of the gender, people are going to be looking that they've already adopted the behavior and the clothing, the mannerisms of the other gender, their experienced gender. Then they're going to start doing some of the hormone therapy before they ever look at any of the surgical options. So it's going to go in that step. Many people with this diagnosis might feel uncomfortable being regarded by others or functioning as their assigned gender. So make sure you ask them how they want to be addressed, what name they want to be used, if they want she or he or something different. Those are going to be important things to look at when you're working with that person. There are agencies that specialize in working with a person that has a gender dysphoria issue. So that might be something to refer them to if they're looking at some long-term treatment. Okay, so this is a new category, disruption, impulse control, and conduct disorders. We're going to be looking at conditions involving problems in the self-control of emotions and behaviors. So we're going to have behaviors that are violating the rights of others. It might also bring them into conflict with societal norms or authority figures, including the point of perhaps being arrested or incarcerated. You're going to see this a little bit more often in males and females, but you definitely will see it in both. And they tend to start in childhood or adolescence. So you're going to usually see this starting at a younger age, and it might continue on for adulthood. One that usually starts, could start as early as preschool and is not often seen later than early adolescence, as oppositional defiant disorder. So the main feature you're going to see here is that pattern of angry or irritable moods, argumentative and defiant behaviors, and vindictiveness. It's not going to be unusual to show behaviors without the mood. So you might see people being very defiant, being very argumentative, behaving badly, perhaps even destroying property, without necessarily having that negative mood. For this diagnosis, note that this might be confined to only one setting. So the kids might be okay at school, but at home they're acting out. Or you might not see any of these behaviors in the hour a week that you're seeing them for therapy, but the parents' report is going to be really important because you're going to want to hear how that child is actually acting out at home. Symptoms are going to be very problematic of the interactions that they have with other people. Most of these kids are going to justify their responses as reasonable, so they're reacting to something that they believe is a good reason for why they're acting out this way. But it's generally something that is very minor, so perhaps a teacher asks them to sit down and the kid explodes, or the parent asks them to bring their dishes into the kitchen and the child responds by breaking the dishes on the floor. So it's going to be something that they think is a reasonable response to the request or to the situation of what's happening on. You're going to see this mostly in families where child care is disrupted, where there's multiple caregivers, inconsistent caregivers, basically where the child is not feeling secure, so they're acting out in response to that. I would say I've also seen this in cases where there's abuse in the home, especially sexual abuse, so that's something that you would want to keep in mind and maybe even screen out. Not a super high prevalence, about 3%, but I think you're going to see this at least fairly often in kids that you're working with. So this is kind of the first step. Later on we're going to look at conduct disorder, and that we're often seeing the oppositional defiant disorder moving into conduct disorder at an older age. Intermittent explosive disorder is kind of in between the two, and can be in adults as well, though rarely older adults. It's going to be mostly people in their 20s and 30s. This is where you have impulsive or anger-based outbursts with no warning or very little warning. And they tend to be very short outbursts. So people are fine 1 minute and then the next minute they explode, and then 5 minutes later they're fine again. Again, this is often going to be in response to something very minor. So a teacher asks them to sit down, they explode. Their boss says that they need to redo a report, they get angry and quit the job. So it's going to be very minor situations that have a major response. In between the really big episodes, you might have smaller episodes. So there might be issues where people are talking back and arguing before they get to the point of breaking dishes or quitting their job or something like that. If you're looking at kids, they have to be at least 6 years old before you can diagnose this. You're going to see this mostly, though, in later childhood, adolescence, a little bit in the older ages before the age of 40. This is one where you're going to rule out an adjustment disorder. So if the person is in the middle of a situation or a stressor that would be causing an adjustment disorder, diagnose them with the adjustment disorder, and hopefully within that 6-month time frame it'll dissipate and we won't have this issue anymore. Again, that history of physical or emotional trauma in that first 2 decades or early life, that's going to be one of the primary risk factors. So if you're looking at a kid who's gone through some form of abuse or neglect, it's going to be fairly often that you're going to see some diagnosis in one of these categories. So again, make sure you do some screening in that area. Conduct disorder is kind of the most severe of all of these. And like I said, we often see people start off with that first diagnosis, the oppositional defiant disorder, and then as they get older, it develops into the conduct disorder. Make sure you look at the different specifiers and subtypes. There's a lot of them for this one, and you're going to want to be very specific when you're looking at the diagnosis. Okay, so we're looking at repetitive and persistent patterns of behavior that now we're getting to the point where the basic rights of other people are being broken, or any kind of age-appropriate norms or rules are going to be violated. So now we're looking at causing physical harm to people, causing physical harm to animals. That's going to be one that you're going to note a lot. Property loss, tearing up the schoolroom, so breaking things in the classroom is a very common example that you're going to hear. Deceitfulness or theft, so stealing things from other people, or any other kind of serious violation of rules. These are going to be the kinds of things that you're looking at for conduct disorder. You're also going to see them being very aggressive towards other people. So you're going to probably see them getting into fights a lot, whether it's at school or at work, or even with their family. So I had about a 15-year-old girl that I worked with who had been through some pretty serious sexual abuse, and she was also diagnosed with conduct disorder. She was physically fighting with both of her parents. She was running away from home for short periods of time. She was skipping school a lot. Lots of behaviors like that. I don't know that she was causing any property loss or damage, but she was causing physical harm to people. She was beating up her parents. She was definitely stealing things from the house and selling it to get cash, and violating rules like curfews, the not coming home at night, skipping school, lots of rules that she was violating. So that was one example that I had seen a while ago. You might see the bullying or threatening behavior. So like this girl would often bully and threaten her parents before she would physically beat them up, as well as bullying the sibling. I don't know that she physically fought with the sibling as much because the sibling did not stand up to her to try to stop her from engaging in the behaviors. Onset's usually going to be middle childhood through middle adolescence. The 15-year-old kind of fell right into that. It's been a behavior that she was exhibiting for a couple of years, and she was 15 at the time. Rarely begins after age 16. That doesn't mean the symptoms won't persist through age 16, but you're not going to see the beginnings of it after that point. Prevalence is usually around 4%. Again, look for kids that have been through some kind of abuse or trauma. So one of the other things that you're going to look at with conduct disorder is, remember that path that we talked about where we started with oppositional defiant disorder. People moved into conduct disorder, and if this is not addressed or treated, what people might actually move into is antisocial personality disorder. And we'll talk about the personality disorders in a couple weeks, but note that that's kind of a fairly common path, that if you're working with an adult with an antisocial personality disorder, you're going to look for that previous diagnosis of conduct disorder or even that oppositional defiant disorder for that pathway into adulthood. And we're going to actually look at substance-related disorders next time, so that is all for this week.